Just like what I said in the cholinergic drugs, it's very important to master first how the neurotransmitter behaves and the receptors work because the drugs will really be classified based on those. And so the adrenergic drugs are not so much different, thus we see a similar layout. Wherein here I will focus first on discussing the cycle of our catecholamines, and then we will kick off with the discussion of the receptor subtypes before we ultimately go to the different adrenergic drugs and their uses and adverse effects. So, before everything else, I just want to show very briefly the structures of the three catecholamines, dopamine, norepinephrine, and epinephrine. And they are called catecholamines because of the two words. Catechol, which refers to this benzene with two OHs arranged in a 1,2 or ortho fashion, and amine, which is the classical NH2 group. And as you can see, all of the three have a catechol ring, and all of the three have an amino group. So they are appropriately called catecholamines, a mix of both. And they all come from the amino acid tyrosine. This will start the journey as they are synthesized in the neuron, the presynapse, and then we will go as far as the contact with the receptors and even their termination. So to start with, tyrosine is first converted to DOPA, the first metabolite in this process. Sometimes people would like to call it in a more complete name, L or levodopa. And then in the next step, levodopa is converted in another step to, in a single step to dopamine, which is the first of the three to appear. And then dopamine is stored in vesicles, which you should remember is similar to how acetylcholine is stored in vesicles in cholinergic neurons. So there's storage here, and there was synthesis before. However, synthesis did not stop here because inside the vesicles, that's where the conversion of dopamine to norepinephrine happens. So here is norepinephrine synthesis. Now, for the vesicular release of these neurotransmitters, usually our trigger, similarly to the cholinergic division, is the influx of calcium ions. If that happens, of course, we will now have our catecholamines ready to mingle and bind and cause effects depending on the receptors they interact, which I will talk more about later. Do note that I only wrote norepinephrine here to conserve space, but of course, this could have also been epinephrine or dopamine since they are all neurotransmitters of the adrenergic division. Eventually, the binding will stop and there will be dissociation, and termination will be the last step. It can either be by metabolism, by these two enzymes, or by reuptake. So first, metabolism. There are two enzymes that can do that for our catecholamines, as opposed to just one for acetylcholine, if you remember. One of these two is MAO, which stands for monoamine oxidase. This is where showing the structures come in handy because since we already saw that the amino group is evident in all of the three, and there's only one of those, then once we oxidize them, we can just assume that the resulting product will be inactive. Similarly, COMT, though it does a different thing because it has a different name, catechol O methyltransferase. So once it transfers a methyl group to the oxygen of those catechol rings, I'm talking about these guys, similarly, we stop the effect. So this is termination by metabolism. Ironically, despite being complicated because we have two enzymes and all, this is said to be a minor contributor to the termination of adrenergic effect. The more dominant actually is the other method, which is reuptake. Note that this is unique to the adrenergic division. There is no well-known reuptake way or mechanism for acetylcholine. Okay, so there are usually transporters for this. For example, if you want to talk about dopamine, we have the dopamine transporter. If you have norepinephrine, then we have the norepinephrine transporter. Of course, when you do reuptake, which is to take them back again, because the context is you release them earlier, right? And then since we have these transporters, you can take them back. So if you take them back, they already are removed from this area, from the synaptic cleft. Of course, if it's not in the cleft, it cannot contact the receptors. If that cannot happen, then we cannot see these. So that's termination. Now, we're almost done with the cycle, except that if there are observant peeps out there, you would remember that there was no mention of epinephrine so far. Well, epinephrine can be synthesized from norepinephrine in a single step by an enzyme that I will not name for the sake of simplicity. But unfortunately, that enzyme is actually found in the adrenal gland. So that is where the conversion of norepinephrine to epinephrine happens. Well, unfortunately, since there's no drawing or this is not in the context of the adrenal gland, it is therefore expected to not see epinephrine as well. Though that also does not mean that this will be any different. If this does make contact with these three receptors, it will be similar to how these two others work. They're, after all, catecholamines, all of them. Now, with that said, let's talk about the significant effects of activating the different adrenergic receptors, or in one word, adrenoceptors. Let's start with the alpha. There are two well-known alpha receptors, alpha 1 and 2. Alpha 1 has more effects going on that's relevant for the drugs later to be discussed, which include vasoconstriction, mydriasis, and bladder relaxation, which we can all see listed down previously. So, you can find it in the blood vessels, the eyes, and the bladders. The bladder, so those are also the organs of concern when we talk about drugs acting on alpha 1. When we do target the alpha 2, it's quite weird because you will notice the effect is vasodilation, which is a riddle because, like, why is it doing the opposite of another receptor of the same kind? And the explanation for that is that there are actually complicated ways to explain this, but the long story short is the drugs that are well known to target this are more working in the presynaptic area, which means more or closer to the central portion. And for some long story, which requires some molecular biology details, central activation will cause the opposite of what alpha 1 is doing. Okay. Now, we go to the beta receptors. There are three mentioned in many textbooks, but I'll just focus on these two because the drugs are more focused on these two in the first place. For beta 1, look at the effects. So based on this, what can we probably assume? Well, basically, more of the beta 1 receptors are found in the heart because they do increase heart rate and increase contractility, as we can see here. Or if you want to use the other words, positive chronotropy and positive inotropy, right? Whereas the beta 2 receptors are located in other organs, predominantly the lungs and the uterus as far as their clinical importance goes. So when you have drugs targeting this, you must probably think of things like asthma or pregnant patients. So we just connect the dots, okay? And then finally, we have dopamine 1 receptors, and this has to be noted that we're talking about D1 receptors in the kidney because there are also other D1 receptors and even much more varieties of dopamine receptors in the brain that's central, so we won't talk about it. If you do activate the renal D1 receptors, you will dilate renal blood vessels, the importance of which I will talk about when I go with dopamine in detail in the future. With that said, I think we are now ready to go to the adrenergic agonists and antagonists.